This webinar is kindly supported by Convatec and Essity. The supporting companies have not had any influence on the content of the webinar. We hope you will enjoy the webinar.
Hello everyone, and thank you for joining us. My name is Samantha Holloway. I'm a reader at the School of Medicine, Cardiff University, and I will be the moderator of this webinar. This webinar is the second episode in a series of 3 webinars focusing on the various aspects of surgical site infections and antimicrobial stewardship. The webinar is based on the EWMA document, Surgical Site Infections, Prevention and Management across Healthcare Sectors, published in 2020. This time we will focus on treatment and management of surgical site infections. The webinar will be recorded, so you'll also be able to watch it on demand after a few days. You'll be able to request a certificate of attendance for the live participation in the webinar if you participate in a minimum of 70% of the live webinar. A link to the certificate will be sent after the webinar. The 2 speakers will speak each for about 15 minutes, and after this time there'll be time for questions. Please note that you can type your question in the Q&A box anytime during the webinar. I'm now pleased to introduce the presentations and welcome the speakers in today's webinar. Our speakers are Kylie Sandy Hodgetts, who is a Senior Research Fellow and Senior Lecturer in the Faculty of Medicine and Director of the Skin Integrity Clinical Trials Unit, University of Western Australia. And also Jan Strier. Jan is a vascular surgeon in the Centre of Vascular and Minimal Invasive Surgery, Hospital, Podlesy, and the Salvatella Centre of Non-Healing Wounds Treatment in the Czech Republic. Unfortunately, Kylie Sandy Hodgetts is not able to join the live session, so her presentation is being shown pre-recorded. However, we're really pleased that Mark Collier, who is an independent nurse consultant and associate lecturer in tissue viability, has agreed to join us to answer any questions related to Kylie's presentation, as Mark was on the original author group for this document. So I'd now like to start the first presentation by Kylie Sandy Hodgetts, who will talk about the wound dressings for the management of surgical wounds. And she will be followed by Jan Strier, who will talk about surgical treatment of SSI. Please do add any questions you may have on the presentations in the question box at any time during the presentations, and we will address these after the last presentation. So we hope you enjoy the presentations.
Hi everyone, and welcome to the second series for the EWMA Surgical Site Infection document, Dressings for Prevention and Management. I hope you're enjoying these and learning a few tips and tricks. And again, thank you to EWMA for the invitation to present to you this evening. So today I want to talk to you about dressings for prevention and management, tips and tricks, latest evidence, and what we've essentially covered in the document. Again, I'm Dr. Kylie Sandy Hodgetts, Senior Research Fellow at the University of Western Australia in Perth and the Centre for Molecular Medicine and Innovative Therapeutics, Murdoch University in Perth, Associate Professor. So for the purposes of this talk, I have no potential conflict of interest to declare, and today's presentation will look at key things for you to take away. So we're going to address the principles of acute wound management. We'll look at the types of dressings that you may have available in your clinical armamentarium, and we're going to touch on the evidence for clinical practice for the use of these types of dressings. And I'm sure there'll be some time for a Q&A. If I'm not able to join you on this presentation, I'm sure my esteemed fellow clinical colleagues will be able to answer your questions, or you can get in touch with me at my email address, kylie.sandy-hodgetts@uwa.edu.au. Happy to answer any questions you have. So let's just quickly touch on the number of surgical procedures that are carried out every year. And there's an estimated 313 million around the globe, quite a lot of surgery each year. And when we create an incision or an insult to the skin integrity, the healing trajectory kicks in around 72 hours after the insult. And of course, we have the normal inflammatory response. If we've got a normal healthy patient, we can anticipate it 6 to 8 weeks for full closure. And most of you, or some of you, may not actually be dealing with a normal healthy patient. So you can expect delays in wound healing, particularly for those that are immunocompromised or have other known delayed wound healing factors. So complications such as infection or dehiscence do occur and may be associated with microbial factors or may not be. So they may also be contributed to patient-related factors or lifestyle factors after the surgery. The most commonly reported time of an SSI or SWD is in the post-operative period, so that's between day 7 to day 9. And as we now know, they're most commonly managed in the post-discharge or community nursing setting. Now, I want to draw your attention to Halstead's surgical principles, and he was one of the first to espouse the principles of incision wound management, particularly in excellent surgical technique. And he really drew attention to the handling of the incision and the tissues and the peri-wound skin around that incision line. And he refers to gentle handling of tissue and obtaining meticulous homeostasis and preservation of blood supply. He's a firm believer in strict aseptic technique and reducing tension on the tissues. So this was during the late 1800s, where people were beginning to understand that reducing any insults to the incision line would certainly lead to improved outcomes for the patient. Importantly, as well as accurate tissue apposition, so that's really good alignment on conduction of the incision, and the eradication of dead space. Elimination of dead space is key. Dead space can encourage pooling of inflammatory mediators, exudate pus, or may be a housing component for microbial activity. Looking at what is happening in theatre and perioperative care in terms of incision wound management, there is a lot of discourse around bundles of care in perioperative care, and there's limited evidence to support this. However, there are a number of studies that have shown a reduction in the occurrence of surgical site infection with bundles of care that are specific to their particular local area. So if you are considering the use of a bundle, or you already use a bundle in clinical practice, it's important to build these bundles of care following the identification of local gaps or deficits where you think that there are contributing factors to your surgical site infection rate. So essentially you need to take a deep dive and look at some of the statistics and some of your performance indicators at your local institute to see where you think or to determine where you can improve clinical practice. But when we're talking about surgical wound management, the primary or the key tenets are to promote healing by primary intention. We want to assess and reduce the risk of complications where possible. We need to protect the incision site with a form of a cover dressing and use aseptic non-touch technique at all times, particularly if you're doing a dressing change or removing staples. Following that procedure, the aseptic non-touch technique is key in preventing contamination of the incision site. And of course, we want to be able to identify quite early if a complication such as SSI is occurring, so we can prevent its escalation into a chronic wound status. Recently, I worked with a team in the APAC regional surgeons, and we talked about what are the key characteristics of a dressing when we're trying to choose a dressing for incision management, how long should we keep it on for, and what is it that we should be using? Now, Reedy and Morgan-Jones also did a very similar document for Europe and the UK. And interestingly, we had similar findings. Most importantly was the comfort of ease of removal for the patient of the dressing. We need to apply the principle of undisturbed wound healing in cases where appropriate. And we want to allow visualisation of the incision line for monitoring the wound. So we're not disrupting the dressing and the wound bed interface. Interestingly, there was quite a range on the dressing wear time and the frequency of changes with minimal agreement. However, clinical guidelines do recommend currently around the world that you leave the dressing on for 48 hours, although there is evidence to suggest that a longer wear time reduces the occurrence of complications. So when we're choosing a dressing for post-operative incision management or prevention of SSIs, let's have a look at the types of dressings we have. And it's no surprise, there is a great panacea of wound dressings out there. You walk into the dressing cupboard or you look into your bag and you think, which dressing am I going to use? And probably the most important question is, what is the condition of that incision site? Does it look inflamed? Does it look infected? Use your visual cues and clinical signs and symptoms, which we discussed in the first episode of this series, around assessing and diagnosing of infection. This will drive your choice of dressing. But we do have a number of dressings. We have gauze, non-adherent pads, foam dressings, calcium alginates, hydrogels, negative pressure wound therapy. We have interactive dressings such as the DAC Silver Honeys or the PHMBs, and of course iodine. So all of these dressings will come down to ultimately your clinical judgment, whether you are dealing with an infected wound and what's the primary goal of care for this particular individual and their incision wound management. And of course, refer to your local policies. But as we know, clinical practice is underpinned by evidence. And if we recall, Sackett first espoused evidence in the 90s in BMJ, and it clearly articulates that evidence-based practice is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of the individual patient. And why is this so important? When we're building clinical guidelines or consensus documents, we need to know what levels of evidence we're working with, and particularly in relation to the choice of dressings, to determine whether the choice of dressing you're making is backed up by hard science. So of course, guidelines are put together using a systematic methodology. So that's either a Cochrane review or a Grade Pro approach, and you can read more at the Grade Pro website. Essentially, guidelines assimilate and disseminate pooled evidence and provide graded recommendations. And of course, you have the systematic reviews, which pull the data from randomised controlled trials, which are level 1 evidence studies. They're higher in ranking in terms of the science and the methodology used to conduct these trials, and the empirical and scientific rigour for putting these studies together. So when you're looking at the evidence for the use of any particular type of dressing in clinical practice, ask yourself the question, does this have level 1 evidence? What's the bias involved in the strength of the study? So Joe Dunville's group in 2016 published a Cochrane systematic review which investigated the dressings for the prevention of surgical site infection, and the team found some very interesting results. It's fairly clear from their synthesis and analysis of the pooled data is that there's limited efficacy for prevention of SSIs using advanced wound dressings, and that is, there's really no evidence to choose one dressing over the other. And why is this so? This paper yielded a lot of studies, lacked low precision, high bias, and were not level 1 studies. So it's not to say that there's no evidence, it's just the evidence quality is very limited. And the World Health Organization in 2017, who used a Grade Pro methodological review, also came up with very similar findings. And what these documents are telling you is that the jury is still out in terms of evidence-based practice or level 1 evidence-based practice to inform clinical judgment around the use of dressings for prevention of surgical site infection. Of course, there's been a lot of discourse around negative pressure wound therapy, and like other dressings, they also have a place in clinical practice. However, Jill Norman's group also revealed no clear difference between negative pressure wound therapy and standard care for wounds healing by primary closure, and that was published in 2020. They pulled 44 RCTs, and the procedures were from a range of wound classes, so from clean or clean contaminated surgery. The takeaway here is that these documents are regularly updated, so I'm willing to bet, stand by in a few years' time, there will be updates to these Cochrane reviews. And there's a number of trials that have been recently published which have shown favourable results for some particular types of dressings in the prevention of surgical site infection. However, we must wait for these review documents to be published and go through a rigorous peer review process. But let's just remember, prevention and management is more than just dressings alone. We need to consider lifestyle factors, pre-existing comorbidities, and surgical factors as well. How are we managing this patient when they return to the home care setting, and how clear and how valid are our post-discharge surveillance programs for early detection and clinical management? So where to from here? Further powered level 1 trials are certainly required to determine the efficacy of an intervention or a particular type of wound dressing compared to standard practice. This will inform the advancement of clinical guidelines. Dressing choices are often driven by evidence-based practice. However, the goals of care and wound assessment play a key role in how you treat the incision and how you manage that patient in the post-discharge surveillance period. Always refer to your local policies in regards to prevention and management of SSI, and incorporate a multidisciplinary approach to patient management in the primary and community nursing setting. So again, thank you for the opportunity to present some information on the choices of wound dressings around surgical site infections. There's further to read in our document, so please do avail yourself of it, free to download from the EWMA website. And thank you again to my fellow colleagues, EWMA and Wounds Australia, for the opportunity to contribute to this document. Have a great webinar series. Take care, and thank you.
So thank you to Kylie. Just a reminder, if you have any questions for Kylie, please do pop them in the Q&A, and we'll come to them after the next presentation. So I'd like to introduce now Jan Strier, and Jan is going to be talking about surgical treatment of SSI. Thank you, Jan.
Thank you, Sam, for a nice invitation. Hello, everybody. My name is Jan Strier. I'm a vascular surgeon and editor of EWMA SSI document. Welcome at the second part of a webinar series dedicated to the surgical site infections. I'd like to wish you a nice day and peaceful Advent time. In my presentation, I will focus on the surgical treatment of surgical site infections. I have no potential conflict of interest to report. As we mentioned last time, the majority of surgical wounds is closed at the operating hall and healed by primary intention. To achieve primary closure, it's necessary to obtain clear uncontaminated incision and surgical closure of the wound up to 24 hours after opening. Wound closure is the goal of SSI healing also, but presence of infection influences the healing process, so the treatment has to be adapted to different needs. General algorithm of SSI treatment starts with SSI diagnostics. It's necessary to set the type of SSI and identify the cause of infection. This phase can be a part of the next step, local management of the wound, followed by targeted systemic antibiotic supply. Local management of SSI involves wound opening and drainage. If an implant is present, the treatment has to take regards on this. After overcoming the infection, we focus on the wound closure, which can be achieved by moist dressings and secondary or tertiary intention healing, or by the negative pressure therapy. Healing by secondary intention is a time-consuming process in which moist dressings play an important role. It follows the inflammatory and proliferative phase of healing and is dependent on the granulation tissue production and epithelialization. Daily closure combines both techniques. As soon as inflammatory phase is managed by the open healing, granulating wound is closed by a suture. It speeds up healing, decreases the risk of reinfection, and improves the scar resistance to tensile strength. Treatment of surgical site infections requires a complex approach involving treatment of the infection itself, affected human body system and its function, the wound, and overall patient health status. Treatment varies according to the type of SSI, anatomic region, or other factors. Non-surgical treatment is based on topical antimicrobial and antibiofilm treatment of a wound and, if it's indicated, targeted systemic antibiotic treatment. The choice of antibiotic is derived from its known resistance, tissue penetration, and patient comorbidities. Surgical treatment stands on surgical treatment of infection and debridement of the wound, together with the recovery of the human body functions, like ensuring the sufficient circulation and blood supply, enabling patients' mobility, achieving skin integrity, and so on. In superficial and deep SSI, surgical treatment can be a part of the diagnosing procedure. It covers, for example, revision of the wound, release and drainage of a pus or nephrectomy. These interventions should be done as soon as possible after making the diagnosis. Where symptomatology of acute SSI is more evident, symptoms of chronic SSIs can be masked and they have been actively sought by clinicians. Another factors influencing the type and extent of surgical treatment are the range of infection, type of previous surgery, presence of implants, and their contact with infected tissue. So let's go step by step through the treatment of SSI. Citation from Latin says, ubi pus ibi evacua. And the first step presents revision of the wound to set the range of infection. Taking representative biological material is essential for finding the right antibiotic treatment, and I will talk about this issue in a while. Surgical treatment of the wound follows in superficial and deep SSI. In organ space SSI, we also use other mini-invasive and imaging methods for selective drainage and sanation of infectious focuses. Management and manipulation with attacked implant can differ among medical disciplines. Infected implant used to be removed from a body with or without implant substitute. Bounded acute infections out of the implant site can allow to leave the implant in place, very often in conjunction with negative pressure therapy and delayed closure. For relevant microbiological assessment, we need to take representative samples. Wound FAB is satisfactory for majority of superficial infections. Deep infections can be assessed by tissue biopsies and aspirates. Implant-associated SSIs and chronic infections often need to take prosthetic joint aspirate, periprosthetic biopsies, samples from prosthesis itself, or fixation devices. Where possible, we collect specimens before starting antimicrobial therapy. They should be transported as soon as possible, and in cases of suspected prosthetic infection with low virulence organisms, culture may be extended to 14 days. The last chart describes the most frequent causes of SSI. In this iconography presents a superficial SSI after umbilical hernia repair. In this case, removal of skin suture, separation of wound margins, drainage of the wound, cleansing by antiseptic lavage, and surgical debridement are adequate. The wound is closed by secondary intention, wound healing using moist dressing. Deep incisional SSIs require revision of the whole wound for the more careful examination of affected fascia and the viability of muscles and drainage. Usage of hydrogen peroxide is not recommended due to high risk of gas embolism and its cytotoxic acting. These procedures are followed by surgical debridement, targeted systemic antibiotic treatment, negative pressure with or without installation, management of infected implant, and wound closure. Negative pressure offers many advantages and effects on SSI treatment, and it has stable place in management of SSI and wound dehiscence. According to SSI management, the most important actions are contraction of wound margins and stabilization of the abdominal wall, drainage of the wound and management of infectious exudate, assistance in local inflammation and infection signs decline, assistance in granulation tissue formation, and better availability of antibiotics due to local hyperemia. As an example, you can see a case study report of 35-year-old man suffering from infection after sacral dermoid removal. The symptoms of the SSI developed the 6th day after surgery. We applied negative pressure therapy for 16 days. After then, he was released from our hospital with a negative pressure device as an outpatient. We continued with antiseptic dressings, and the wound has been healed within 6 weeks. Another example is here, a case study report of SSI after ventral hernia repair. The mesh has been already extracted. You can see the wound, its volume. We decided to use negative pressure for 25 days. So you can see the contraction of wound margins and the reduction of wound volume. And finally, this patient has been released home after 4 weeks after surgery, and the wound has been healed within 5 months. The last example is infected stump after major amputation of the left leg. In this case, precise debridement was very important, and you can see usage of a hydrosurgery device for this purpose. Then we continued with negative pressure for 25 days, and it has been followed by delayed closure. Organ space SSIs often requires readmission into the acute care settings, targeted antibiotic treatment, careful revision, and exploration and drainage. We often work with the algorithm of open abdomen and open chest management. In vascular surgery, the class of majority wound is clean. After aortic interventions, the SSI incidence ranges from 1 to 2%. After lower limb bypasses grafting operations, the incidence is between 10 and 20%. There is more than sextuple increase in in-hospital mortality associated with deep and organ space infections, high risk of major limb amputation, and high risk of stump infection in vascular surgery. In vascular patients, treatment of the SSI along with ischemia is necessary for limb salvage. The most frequent life-threatening complications of vascular graft infections are acute bleeding from anastomosis, acute gastrointestinal bleeding, pseudoaneurysms, acute limb ischemia, arterial thrombosis, and sepsis. Plenty of material for grafting are available at the market, but regarding the long-term vascular graft patency and its resistance to infection, the best choice seems to be autologous vein graft. On this slide, you can see per-operative pictures of infected aortic prostheses used for aortal femoral bypass. Infected prostheses had to be removed and placed and replaced by another graft. In this patient, infector of aortal femoral bypass resulted in major amputation of both legs. Superficial and deep SSI can be treated in a conservative manner by antibiotics, negative pressure therapy, and antiseptic moist dressings. It's important to protect the graft from infection and to cover prosthesis by a muscular flap or vital subcutaneous fatty tissue. Surgical site infections, Shilagi grade 3, often needs to explant infected prosthesis together with new vascular reconstruction using autologous vein. The best solution for treatment of infected aortic reconstructions seems to be deep femoral vein reconstruction of the abdominal aorta, as you can see on the next slide. So here is infected epsilon prosthesis, prepared deep femoral vein for grafting, and on the last picture, there's bypass in the retroperitoneum. Orthopedics is another discipline with high number of implants used during the surgery. The class of majority wounds is clean, and the SSI incidence after total hip arthroplasties is around 1%. Prosthetic joint infections is connected with the presence of biofilm. Biofilm bacteria can attach the hardware components, cement, bone, or fibrous tissue. Detached clumps of biofilm can also be found in a joint fluid. Acute implant infections are caused by rapidly growing planktonic bacteria. Chronic, subacute, or indolent infections are harder to diagnose, very often derived from bacterial biofilms on and around the implants. Biofilm provide a reservoir from which bacteria can periodically disperse into surrounding tissues and joint fluid, and the only viable recourse is to remove the affected implant. As future directions in prevention and treatment of biofilms in orthopedics, we can mention new devices, materials, and technologies covering biosurfactants, antimicrobial silver nanoparticles, or antibiotic-coated metals and cements. More research is necessary for clinical recommendation to use anti-biofilm vaccines, biofilm disaggregating agents, quorum sensing inhibitors, or other agents. So to sum up the SSI treatment issue, I'd like to highlight that the general principles of superficial and deep incisional SSI treatment in different surgical disciplines are the same, based on revision, drainage, and antimicrobial treatment. If prosthetic infection or organ SSI are present, it's necessary to apply specific techniques and approaches. According to this knowledge, it's clear that type and timing of the treatment vary among surgical specializations, and they need well-trained and educated professionals and specialists. Thank you for your attention.
Thank you very much, Jan. So welcome, Jan, and welcome, Mark. So we're ready for your questions now. We haven't had anything come into the question and answers yet, so please do post your questions if you have any. But Mark, are you able to turn your camera on? If not, I'll come to you first then, Jan. Thank you for your presentation. I wanted to ask you about the SSI incidence in lower limb bypass grafting procedures. You mentioned it was 10 to 20%. Can I ask you, does that seem high, or what may be the reasons when we compare it to incidence in other procedures? Why would it be that it seems quite high?
The incidence can look high, but we have to know that when we want to save limb and when we make a bypass, it's very often a critical limb ischemia. So it's ischemic place, and the healing is delayed, or in some circumstances, it's impossible to heal this wound when the ischemia is not treated. Another problem is that those limbs are not only ischemic, but very often with a wound, with infected wound, with gangrene. And so this is the reason why the results or the incidence of SSIs can be higher. And maybe the final voice is that surgeons want to save any limb. And when we try to find the boundaries or the limits, we very often go over the limits when we try to save the limb. So maybe in these cases, the number of SSIs can be higher.
Yeah, I see. Okay, that's interesting. You also talked about the symptoms of acute and chronic SSI. Yep. I just wondered if you could expand a little bit more on the symptoms related to chronic SSI and what people should be looking for when assessing a wound.
It can be a fever, not high fever, but only a little bit increased. It can be pain, and we can find lab findings which we are not able to answer why there is a high level of leukocytes, for example, or high CRP or other markers of the inflammation. So in vascular surgery, the tragedy is when the first sign is bleeding, because we have to act acutely. And usually when we want to treat infection, we need some time for preparation.
Okay, thank you, Jan. So there's probably a question for both of you, actually, Jan and Mark, because both Kylie and Jan, you talked about negative pressure wound therapy. I wonder what both your thoughts are on the use of it on closed incisional wounds prophylactically to reduce the risk of SSI. So Jan, perhaps I can come to you first. Do you use it in your clinical practice?
I'd like to use it, but it depends on the budgets of the health insurance companies. And in Czech Republic, it's allowed to use it, but the rules are strict. So it's not the first choice for all the patients. But I think that as I mentioned in the first seminar, it's really a powerful tool how to improve healing, and in high-risk patients, I recommend to use it.
Yeah, and I think that's the point. It's about high risk. And Mark, I don't know if you want to pick up on this. The first question was around, is it useful to be using closed negative pressure wound therapy, on incisional wounds? And, how do we know who is at high risk? So Mark.
I mean, I think what's really important, I think everybody is convinced that negative pressure has a part to play in wound management and in wound healing. There's very little evidence to say that you should use topical negative wound pressure on all wounds to prevent surgical site infection. So that would be not a cost-effective approach if it was put on every wound prior to every bit of surgery. However, there is a growing body of evidence, as Kylie alluded to in her presentation, with the advent of a lot of much smaller negative pressure devices now, much more portable. And so therefore the patient, if they're deemed at risk, could be transferred out to the community with that device rather than the larger devices, which tend to be used in hospital for all the right clinical reasons. So there is a growing body of evidence that it may be very appropriate for patients who are deemed at risk. And what's important there is that the clinicians prior to using it should have a pathway that identifies those high-risk patients. And that should be done in combination with all the staff involved, the multidisciplinary team, obviously the knowledge of the particular products that are available to them. And as Jan has alluded to, sometimes that's a financial decision, unfortunately, rather than a clinical decision. But it's identifying those patients who either have had a history of recurrent infections when they've had surgery, or they fit a defined at-risk group. And then, yes, topical negative pressure certainly should be considered. And I think the evidence that's been published recently is suggesting that maybe the guidelines will change in a couple of years' time, as Kylie says, once that growing body of evidence is reviewed and looked up.
Yeah, okay, thank you, Mark.
And I think that we have to say that from the therapeutical perspective, we can see a really big change in results and perspective of patients with surgical site infections when we use negative pressure therapeutically, especially in abdominal surgery. So the results within the 10-year period are completely different, and it's because of negative pressure.
Okay, thank you. So Mark, you mentioned pathways, which kind of leads me to something Kylie was talking about in terms of skin bundles. Yeah. And I just wondered if we could just talk about that for a minute or so in terms of, she mentioned, you know, the barriers to resources and settings in implementing skin bundles. So I wondered if you had any thoughts on that.
Yeah, I mean, certainly in my experience, and there is a case for developing skin bundles for surgery in lots of cases, and particularly the high risk cases such as cesarean sections, which have shown to have a high risk of surgical site infection and just general dehiscence. So I think with skin bundles, they're really, as Kylie alluded to, a local response to a clinical need. And they develop the clinical guidelines. So surgical siting guidelines, they're NICE or any other body produced, they are just a guideline. And the intent is always that people utilize the information within those. And of course, the EWMA surgical site infection document to develop their local skin bundles in relation to specific clinical conditions such as cesarean section, surgical wounds, as an example. But certainly we've found them very useful in the local setting, and they help to identify that issue. And they help also to, for want of a better word, stimulate the debate as to whether other techniques should be incorporated, and allows people to look at the evidence and the technologies that are local to them to then have an agreed sort of approach to that surgical procedure, both in theatre and post-surgery.
Yeah, thank you. And sorry, well, that was my, I misled you a little bit by saying skin bundles. I've got skin on the brain,
okay.
But
no,
of course I meant SSI bundles, but yeah, so thank you, Mark. So that brings us towards the end of our webinar. So I'd like to thank you both for taking part in the webinar, and thank you to those who joined us today. Don't forget, you'll be able to access the video recording of the webinar on demand via the EWMA website within a few days. We hope that you'll join us for one of the next EWMA webinars. The next webinar is the third episode in the SSI webinar series, which will be held on Monday, the 13th of December. And this webinar will focus on future challenges and cross-sector management. You can keep yourself posted about future EWMA webinars via the EWMA newsletter, our social media or website. And finally, we hope to see you at the next EWMA conference in Paris in February 2022. Thank you again, stay safe and have a good day.